it will be in 1 second. I'm just going to YouTube. So later on, we can send you the link of the talk. Just easier in this way. Okay, start on YouTube. Later on, we can send you the link of the talk. Just easier in this way. Okay. You guys see the monitor? Anybody have any complaint about the monitor, the presentations, the voice, anything? Can I start?
It's clear now. The voice is clear.
Try to mute yourself. Okay, great. Again, this is one of the academic days. So please and kindly, if you wanna unmute yourself, you should use a headphone, or you should be in an isolated room without children with you because they are too noisy. I'm sorry, yeah? So please make sure that there is no noise around. Okay, Bismillah ar-Rahman ar-Rahim. So this is one of the half academic days for the fellows. For those experienced neonatologists, this is not something like a conference, it's just a review. So as if we are reading for an exam, or we are reviewing as a topic. So, and please mute yourself. Choose mute yourself, okay? Who's unmuted? Rula, mute yourself, please. So mute yourself, please. So this topic today is about respiratory problems, and in this half academic day, we'll be talking about some of these problems, and we'll start the first session, TTN, and then we'll move to RDS, and finally we'll go chronic lung disease. Now, they are in order of increments. So the shorter one is the TTN, and then a little bit longer RDS, and the most long is chronic lung disease, because chronic lung disease is almost all the neonatology. So what is the objectives of this talk is we talk about definition. So please mute yourself. Arula, please mute yourself. Okay, so the objective is to define what is TTN, and the most important part, I think, in TTN is the pathophysiology, and we'll talk about epidemiology, clinical presentation, differential, how to evaluate, treat, what is the complication, and what is the prognosis. So TTN is first described by Avery, and if you guys don't know, Avery is the guy who started the Avery textbook of neonatology. So Avery and co-workers in 1966, they described something that the lung of a baby cannot be cleared, or there is a delay in clearing. So as the name implies, it is very, because it's transient tachypnea, TTN, transient tachypnea, it is a transient, it's a for short time, it's a benign, it's a self-limiting. It usually affects the late preterm and term gestation. And if you say why late preterm and term, the reason is because before late preterms, in premature babies, it's kind of mix up between, even if there's TTN, there is mix up with RDS. So it is not very clear, isolated tachypnea of newborn. Looks like more mild RDS in babies born before late preterm. So, and because it's transient and it's a tachypnea, so it's present with tachypnea because it's mild, kind of respiratory distress, and causes some retraction. And if you are not monitoring the saturation, you can, most of the time, we pick it up by decrease in oxygen saturation. And when we say decrease, that's mean a decrease that will improve after providing oxygen, or in FiO2, or that's mean if somebody is not aware of what is IO2, it's a fraction of inspired oxygen. The most important part is pathophysiology. So the process of clearing fetal alveoli, and remember there is difference between amniotic fluid and lung or fetal lung fluid. And this is guarded by remaglutidus, guarded by the larynx. So there is a gradient, or there is a kind of membrane, but the membrane is not existing between the amniotic fluid and fetal lung. And the process of clearing fetal alveolar fluid begin before term birth and continue through the labor and probably a few hours after delivery. In late gestation, in response of labor, there is increased concentrations of catecholamines and some hormones. And the mature lung epithelium, the purpose of that epithelium in fetal lung is to secrete fluid. So that will be switched to another job, from actively secreting chloride and fluid into the airspace, switch it to another mechanism, which is reabsorption of sodium and water. One of the reasons, in addition to the change of catecholamines and other hormones in post after delivery, is increased oxygen tension. And that increased oxygen tension enhances the capacity of this epithelium to transport more sodium and to increase the expression, the genetic expression of sodium transport. Now, if that gene expression reduced, it contributes to inability of immature lung, of not well-formed lung, to switch from being a fluid secretor to being a fluid absorber. There are some factors, especially the steroid, that can upregulate, increase this gene expression. And therefore, some people try to think, why we only use antenatal steroid only for premature baby? Why we don't use it for term and late preterm for that point? But there's no globally accepted standard of practice to do that yet. Now, there are many mechanisms of clearing fluid. The mechanism of clearing fluid are different. So the epithelium, or the apical part of epithelium, has two pathways. Okay, both of them, they are called amiloride sensitive epithelial sodium channel, and they are present in AT1 and AT2, or epithelial cell, apical 1 and apical 2. And as I said, they are amiloride sensitive epithelium. They are of two types. The first type is selective, and the other type is non-selective. So these are two pathways to move electrolyte, and there's other pathway called nucleotide or cyclic nucleotide gated channel. So if you look at here, so you can see that these sodiums, there are two pathways that are called, if you can see it, it's called amiloride sensitive. There is a channel here and the channel here. And they are of two types. They're moving sodium inside the apical cell from the alveolar space. There are other methods that moving electrolyte called CFTR, or cystic fibrosis transport regulator. This is only controlling the chloride. So the amiloride sensitive epithelial transport controlling sodium, and CFTR controlling electrolyte. There are other pathways that control sodium, which is called, is it either through the junction of two cells, okay, or it is through the apical cell. They depend on the ATPase. So they can see that these move sodium and this move chloride. And once you move chloride in, you will move sodium with. Once you move sodium in, you will exchange it with potassium. Once you move sodium in any way from the epithelium to the interstitium, and then the water will move. So it converts from secreting electrolyte in fetal lung to absorbing electrolyte just before, during, and then after delivery. So understanding this mechanism is vital to understand the TTN. Now, the pathophysiology, again, the passive reabsorption of liquid, as we said, occur just before birth. And the magnitude of that absorption varies depending on the pressure in the space, whether it is hydrostatic pressure or oncotic pressure, the pressure in the interstitium, and also the size of the vascular bed. Majority of the water absorbed is through the apical membrane, through the apical area, AT1 and AT2. That occur is through a channel called aquaporine 5. Again, the delay of absorption caused that TTN. When there is delay, the fluid fills the alveolar space. And because it filled the alveolar space, it becomes big and it needs somewhere else to go. So it again filled the interstitiums and then pulled around the blood vessels and goes to the lung fissures. And because the apical, this mechanism of clearing the fluid become inefficient, then lymphatics will come to fight with the apical system and start to absorb. And from the lymphatics goes again to the blood pool. When you get more fluid, as you guys understand, it will interfere with the surface tension. And as you know that the terminal part of the airways and the alveoli have no supporting tissue like the bronchioles, bronchus, and trachea, because there is supporting tissue. So that alveoli and terminal airways depend solely on the surface tension. And the surface tension increase when there is more water, because as you know, the water, there is hydrogen bond. And because of the hydrogen bond, it stick to each other and try to collapse any structure. So having a fat will disperse in between these hydrogen bond and decrease the surface tension. So having more fluid will interfere with the surfactant function and therefore will decrease the compliance. And because of that, of compliance, and the lung becomes stiff, there is increased work of breathing, just tachypnea, to avoid or to reduce that reduction in compliance. And accumulation of fluid in the peribronchial lymphatics and interstitium causes pressure on these and promote collapse of bronchioles. And once the bronchiole is collapsed, because the air goes, it becomes like valve, and the air cannot go back, so there will be air trapping. So, but there is the perfusion of the baby is okay. So there is a good perfusion, poor ventilation, result in hypoxemia. And because the alveoli filled with the fluid, there is no CO2 change. So there will be reduced in ventilation. So at the end, there is hypoxemia and there is hypercarbia, or poor oxygenation and poor ventilation at the same time. Now, there is a study talked about the aquaporine 5 as the channel. Was found is it's greater and increase in number in TTN than the those in RDS and control. And therefore, this finding suggests that upregulation of aquaporin 5 increased reabsorption of postnatal lung fluid. So if we find some drug, for example, to improve or upregulate these aquaporin, will improve on treat TTN and probably contribute to the RDS if the RDS associated with some TTN. So this is a great area if somebody have access to animal lab study and can do that. As we said, because of the fluid and because surfactant is needed to interfere between the love of or the bond between hydrogen atoms, decrease in surfactant also contribute in the TTN. And there's a small study in term infant who was delivered by the elective C-section and have TTN. Compared to those matched, they found that these have lower surfactant function. Now, if you say how you measure the surfactant function, there is we know that the lung maturity is tested by lecithin sphingomyelin, but there is a better study is to study the lamellar body, because lamellar body in pneumocyte type 2 is the organelle responsible of secreting surfactant, and therefore counting the lamellar body will be a good test to test the surfactant deficiency or presence or absence of surfactant. And they used it through microbubble test. So when they measured the lamellar body in the gastric residuals, they found that the lamellar body in elective C-section with TTN, okay, is probably higher than those matched of control or those with having C-section without TTN. Now, the interstitial lung fluid that in the perivascular cuffs of tissue and the interlobar fissure need to be cleared by, as we said, by the lymphatics, but sometimes also be cleared by pulmonary capillaries. So any disruption or delay in clearance of lung fluid resulted in transient tachypnea due to edema. Okay. The fluid also, in addition, increasing or decreasing the compliance, it also press, as we said, on the airways. And it resulted in, let me solve the what's okay. So because of all that, the functional residual capacity of lung will be reduced. And the reason is because of the obstruction of the fluid around, because of decreased surface tension, because of presence of fluid in the alveoli. All of that will decrease lung volume. In addition to all of that, there is air trapping. And because the problem is transient, so we don't have exact pathology or histopathology, because most of these babies recovered. You don't have postmortem. You don't have reason to do biopsy. So the pathophysiology of TTN, what exactly happening, we don't know, because there is a little bit of study. There is in animal, but not in human. Now, what is the epidemiology? It's not very common, but it is not very rare. So the incidence somewhere between 0.3 to 0.6% of term delivery, and a little bit higher, 1% in preterm labors. There is risk factors for TTN because that risk factors can interfere with the or delay the clearance. These are C-sections, whether with labor or without labor, but without labor is more precipitous birth and also preterm birth. As we said, these conditions prevent or decrease or reduce or delay or make it abnormal fetal lung fluid clearance. Okay. Now, the most important risk factors is presence or absence of labor and the gestational age. So the lower the gestational age is more risk of TTN. The more delivery without labor, the more risk of TTN. However, why we say only in preterm or late preterm and term, the reason because in those before late preterms are mixed up with RDS, and it's hard to diagnose. How they present, now they say it is from them, it is tachypnea. So the first thing is increased respiratory rate. But sometimes it's associated with mild, unlikely to go sometime to moderate respiratory distress. And there is the retraction, grunting, nasal flaring, and mild cyanosis. I want to ask the fellows, I want to ask, what is grunting? Anybody can describe what is grunting and why it develops? Fellows? Anybody? What is grunting? Fellows, question, what is grunting? No, don't text. You unmute yourself and talk. What is grunting? No, here. Unmute yourself and tell me what is grunting. Don't text me, don't text me. Don't text me. Unmute yourself and answer. Unmute yourself, say your name and answer the question. What is grunting? No text. No answer? I'm not reading the text. I need everybody to hear. So let me say what is grunting. Grunting is a reverse of respiratory cycle. So normally we breathe in and then we breathe out. And because we know that we have surfactant, we will pause after the expiration. In grunting, there is reverse. So you breathe out and then suddenly you breathe in because you cannot keep the lung collapse. So normally you breathe in, and you breathe out, and you pause. You breathe in, and you breathe out. Well, in grunting, what you do is you breathe out. So you breathe out, and suddenly you breathe in, and that's control at the remaglottids of the larynx to keep a pressure difference and to breathe against closed remaglottids to keep the lung open. I said no text. If you want to answer is by unmuting yourself, introducing your name, and saying the answer. No text. I'm not reading the text. So there is retraction, grunting, nasal flaring, and sometimes there is mild cyanosis, especially if you are not observing saturation. Now, cyanosis should not occur if you are observing the oxygen saturation and you're providing the child with oxygen. Now, respiratory failure is a term that I don't like because there is an actual definition of what is so what is retraction? Rula, if somebody want to answer the question, he sent you a text and you tend to answer the question. So I don't like term respiratory failure because there is extensive talk about textbook type 1 and type 2. Actually, in reality, there is no clear definition of what is respiratory failure. Failure when your organs fail and need support. So actually, if your lung on respiratory support, you are failing. Otherwise, it's not failure. So I don't know how to define respiratory failure if you are okay, but you're ventilated, and maybe you're ventilated for other reasons. So I'm not sure the term respiratory failure. Instead, I like to use pulmonary dysfunction. Okay. So next we'll go to the, of course, with the grunting and tachypnea, there might be an increase in anteroposterior diameter or barrel-shaped chest due to hyperventilation. Auscultation might reveal some sounds. The most important part of transient tachypnea of newborn, its persistence around 12 to 24 hours. In mild one, sometimes if it's severe, unmute yourself, please. And if it's severe, sometimes it goes up to 3 days. What is differential diagnosis? Everything. So sepsis, pneumonia, RDS, pulmonary hypertension. Unmute yourself. Pneumonia, sepsis, respiratory distress, pulmonary hypertension, meconium aspiration, congenital heart disease, and probably many others. Congenital malformations such as diaphragmatic hernia, pulmonary airway malformations, central nervous system problems such as hemorrhage or asphyxia, pneumothorax, pulmonary polycythemia, metabolic disorders, and others. How you evaluate TTN? Well, you need history and a physical exam, radiographic evaluation, and sometimes you need laboratory tests. Now, careful history will find there is prematurity, and sometimes there is risk factors. Risk factor for TTN, but also we are scared of infection. So you need risk factors for infection before you define transient tachypnea, history of meconium, or there is asphyxia. So these are important factors before you define TTN, because TTN is a disease of exclusion. You need to exclude cardiac and neurological disease, maybe metabolic abnormalities. And then you order radiography. The standard or the commonly used is the X-ray, but also remember there is ultrasound. So what you see is in the radiograph, you see a fluid inside the lung. So you can start to see prominent perihilar streaking or sunburst pattern. And also because of the engorgement of lymphatics, you see coarse fluffy density, and that reflects alveolar edema. You can see hyperaeration and widening of intercostal space, and that's because of trapping. You may see mild cardiomegaly because of collapse of the lung. So you can see the wide mediastina, and also you can see wide-filled interlobar fissures. You might see sometimes mild pleural effusion, but there is no pathognomonic finding on the X-ray to tell you this is TTN. The most important is these findings should resolve within 72 hours. And that's a good way to differentiate it from other pathology. And rapid resolution will distinguish it from pneumonia or non-coarse, non-patchy meconium aspiration, because most of the medication are coarse, patchy finding, and it's easy to, but sometimes pneumonia, amniotic fluid aspiration, meconium aspiration can be like TTN, but usually they do not resolve as quick as TTN. And it's important to do X-ray, of course, to exclude other causes like pneumothorax, RDS, or malformation. Remember that there is also lung ultrasound. It has good specificity, but they are not common in neonatal use for a reason that I do not understand. There is also increased pulmonary vascularity in absence of cardiomegaly, which may represent sometime total anomalous pulmonary venous return. This is very rare condition, but keep it in mind. If you have high CO2, like TTN picture, and you're not resolving, keep that in mind. Now, the ultrasound finding in TTN are increase in B line, decrease in A line, double lung point, subpulmonic consolidation, sometimes pleural effusion. What you need to do also, you need to do CBC. Why? To make sure it's not pneumonia or sepsis. Now, please do not send inflammatory factors like CRP and precalcitonin. They are garbage. They are of no use. They are only will increase the use of antibiotics. They have no value. They are wrong, and they're waste of time and blood. And I know some of you love it. I know some of you do it frequently, but believe me, it is useless. Okay, it is the only way, the only benefit of this inflammatory factor is overuse of antibiotics. You might need also to use arterial blood gas to check hypoxemia and hypercarbia. And sometimes you might find some respiratory acidosis, mild one, and mild hypoxia, especially in the first 24 hours. However, if you have severe kind of, why you guys don't mute yourself? Is that hard to mute yourself? Why you are unmuting yourself? So can you please mute yourself? So in presence in TTN, there is only mild type of hypoxia and mild respiratory acidosis. Most of that resolved in 24 hours. If it's severe or not resolved within 24 hours, you need cardiac evaluation. Respiratory alkalosis may reflect central hyperventilation due to CNS pathology or metabolic disorder like hyperammonemia. So keep it in mind. What is treatment? CBC and appropriate culture can give you information whether there is sepsis or not, and you need to start antibiotics. Blood gas will help you to do ventilatory support, whether hypoxia or adequate ventilation. So in short, the treatment is supportive. There is nothing, usually it's mild respiratory problem or dysfunction, and some mild hypoxia and mild hypercarbia. And you need probably some mild respiratory support. But if it's persistent, then remember to do cardiac evaluation. Now, what is the complication? It's self-limiting. There should be no evaluation. However, use CPAP, or any respiratory support, they might increase risk of air leak. They might interfere also with oral feeding, and some people might give some delay the feeding and use of nasogastric tube feeding, and that might delay the parental bonding and establishment of breastfeeding. If you have a question, send it to Rola. I know I muted all because they are 50, 62, and I don't know who is muted, who's in, because they keep unmuting themselves. So yeah, I mute all, so because they are not muting themselves. But you, Rula, you can unmute yourself. Yeah, Rula, you can unmute yourself.
Okay.
Great. So if you have a question, forward it to Rula, and we'll answer it at the end. So it's a self-limiting. There should be no problem. The prognosis is good, and there should be no long-term residuals. However, there is some studies suggest that there is a link between later on childhood airways problems such as airway hyperactivity and TTN. So what is take-home message? Transient tachypnea of a newborn is a benign self-limiting disease. It is a disease that starts within the first 6 hours. and usually resolve within 24 hours if it's mild. If sometimes moderate, it goes up to 72 hours. Usually does not need anything more than non-invasive respiratory support, whether nasal cannula or CPAP. Usually there is no treatment, but it's hard to differentiate it from other problems such as infection. So there is need a detailed history and evaluation to exclude other etiologies such as respiratory infection, cardiac, or neurological etiology. If you want to read about more about TTN, there is a very nice article done by Strostrup about randomized control trial for restricted fluid management in transient tachypnea of newborn. They talked in details about transient tachypnea. So now I'm going to answer the questions. Okay. So let's stop sharing and let's answer the questions. So what you can do is you can unmute yourself, introduce yourself. First, let's see if Rula has questions or somebody asked Rula questions. Rula, any question?
Yes, I have received a number of questions.
Yeah, go ahead.
Dr. Rubia, in the absence of CRP, how you prove infection? As in the CBC, the white BCs have a very wide range and culture results will come later. So you have to start the antibiotic initially.
Okay. Who's asking the question?
Dr. Rubia, Shahzad.
Dr. Rubia, first, you should not start antibiotics or stop antibiotics based on lab test, whatever the test is. This is first principle. Second principle, it's always correct to start antibiotics, but it's always wrong to continue antibiotics if there is no evidence of infection. ESR, CRB has nothing to do with infection. If you are doing it, you will overuse antibiotics. All babies who have a clinical signs of any kind, tachycardia, tachypnea, hypoglycemia, hypothermia, high temperature, respiratory distress, you have to rule out infection. How you rule out infection? You do blood culture and start antibiotics. If it's TTN, it will resolve. If it resolves, stop antibiotics. Why do CRP? Why do ESR? If the culture is not positive within 48 hours, even if it's positive later on, it's usually non-virulent organism. So why you continue antibiotics? So if the baby resolved clinically, why you continue antibiotics? If the culture is negative, why you continue antibiotics? Now, if the baby remain clinically symptomatic and the CRP is low, you cannot stop antibiotics unless you have other reason and your blood culture antibiotics. Your blood culture have to become negative. If you have no risk factor of infection, it's a clean section and there is no labor, why you start antibiotics? It's a clear as TTN. The only indication, ESR is not preferred in neonatology because it's a late marker. CRB is better than ESR. Both of them are garbage, but CRB is better. And the reason, because it's an early. It rise up, it blump up before the ESR. So the only indication or the only use of these when they are negative. When they are negative, they will be no infection. And they will be never negative when you have respiratory problem because you have inflammation. So the only use of antibiotics, when the culture is negative and the patient is symptomatic and you don't know for how long you go. So if the CRP is going down, I continue for 2 days antibiotics. And I don't know to stop antibiotics because the patient is symptomatic. Culture is negative. And patient is symptomatic. So what I do 2 CRPs. If it's going up, I continue 7 days. If it's going down, I continue 5 days. That's one benefit. The second is when it's negative. because the negative likelihood of these is way better than positive. And what is positive? That's another problem. People having CRP of 10, they consider them positive. I don't consider CRP positive unless above 30. So I don't use them. I don't like them. And there is absolutely no evidence. Okay. So when you have more than articles, like I know about CRP, there are more than 100, you weigh which one more. So again, use of these inflammatory factors only will prolong the antibiotics. And we know very important 2 points. Antibiotics overuse cause resistance, increase infection. Antibiotics overuse is a clear indication or clear risk factor for NEC, necrotizing enterocolitis. If you are very, any other questions?
Yes,
Rula?
Dr. Hadi Faqih asking, is lung ultrasound a good choice to rule out or rule in TTN?
Oh, okay, you ask the right person because I love ultrasound.
I know.
So you are asking probably a very biased person about lung ultrasound. Absolutely, yes. Ultrasound should replace X-ray. There is no need for X-ray in an ICU. Everything should be done by ultrasound. Ultrasound has a pathognomonic finding. If you find it, I stop antibiotics. It's pathognomonic it's called double lung point. So what usually you see, increase in B lines, decrease in A lines, you start to see subpulmonary consolidation. And when with more, you'll see fluid accumulation and pleural effusion.
Absence of B lines.
So, no, increase in B lines, increase in B line, right?
Increase in B lines.
Yeah, decrease in A lines.
Yes.
And with time, you will have more matching B lines until you have whiteout lung.
Yes.
Right? But if you see double, why double lung? Because TTN is not homogeneous. It's inhomogeneous disease, not like RDS. And so if you find double lung point, it's actually pathognomonic for TTN. Any more questions?
Yes. One question by Dr. Hashim Azzuddin. Hi, everyone. Is there any evidence or studies in long-term relation between TTN and asthma or cystic fibrosis in future?
Not cystic fibrosis, not asthma, but upper respiratory airway hyperactivity. Because asthma is a multifactorial disease, it's not only one, but they can find there is increase in hyper airway reactivity in patients, those with TN. There is a link, okay? Not very strong, but there is a link, yes. But with cystic fibrosis, no, the pathology is totally different. If there is cystic fibrosis, the beginning was cystic fibrosis, not TTN. So it's a two different pathology. There is no link between TTN and cystic fibrosis. Go ahead.
Dr. Rabi has asked again if there is any, where did the question go? If there is any centrally induced hyperventilation and how to manage it. Centrally induced hyperventilation. I think we are away from the
hyperventilation. Hyperventilation?
This is what she has mentioned. If there is she has mentioned if there is centrally induced hyperventilation, how to manage it, and she has posted the same question twice.
You mean the patient is washing CO2 on purpose? You mean tachypnea for like fever and washing CO2? Sedation. I never seen it, but if you have hyperventilated patient, you cannot control it, sedate the patient. Okay. But I don't know why the baby hyperventilate by himself. He cannot.
If you please, Dr. Rabi, can explain again what was your question. There is a new question from Dr. Ahmed Dana. When to suspect malignant TTN and how to avoid it?
I don't like, Ahmed, the term malignant TTN. I would like the term persistent TTN, but malignant TTN, I don't like it. If it's a persistent more than 72 hours, please think of something else. But sometimes babies may have difficulty in clearing the fluid, and they continue to suffer from TTN, and sometimes they have mild type of pulmonary hypertension as a result. But the term malignant, I don't prefer it. I don't use it. I don't like people to use it. If the TTN more than 72 hours, please think of another pathology.
So I think this also,
Go ahead.
I think this also answers Dr. Sundus Khudair question. She was asking, what is malignant TTN?
Don't use it. It's not existing. It's a clinical term. It's a subjective term. The TTN is the word malignant. It cannot go with TTN. TTN is transient tachypnea of newborn. So I don't like, because there are two end of the spectrum terms. This say malignant, this called transient. So they are not matching. So I don't like it. I don't use it. And I think the best approach is, when you are more than 72 hours, please think of other pathology.
Dr. Yahya, 45 minutes main session finished. We have 15 minutes like break. What would you like to do in that?
Yeah, go ahead. So
if there are questions, shall we still take questions?
People can get rest. So now is, yeah, so we'll start.
Okay, there is a question by Dr. Ahmed Al-Busrati saying, malignant TTN, isn't it the same one associated with the PPHN?
So again, do not use word malignant, because TTN is transient. You cannot be malignant. It's a wrong term. Don't use it. So please, if you have TTN not resolving by 72 hours, think of other pathology. So if there is a TTN and not resolving, and there is pulmonary hypertension, why you are relating the pulmonary hypertension to TTN? It's pulmonary hypertension. Now the problem when you have a fluid, somebody is asking, Rola, or who's asking? Jonathan is asking, what is the possibility of air leak with CPAP? Now, remember that in the first 2 days of life, I am not a person who has CPAPophobia. I have CPAPophilia. So, but in the first day of life, or first and second of life, I don't use high CPAP. The reason, because when you have fluid in the lung is very stiff. And if you force the lung to open, you will do some tear. So yes, there is a good possibility of air leak of using high CPAP in the first 24 hours of life. I use it high if a baby less than 30 weeks, but if baby is more than and tough. And remember, air leak in CPAP is not because of high CPAP or high centimeter of water use. I think it is because the baby is breathing against it. So when you use CPAP, we need to see high blood, sedate the baby very well. Try to control baby resistance, or use variable flow CPAP. The CPAP with a generator. Don't use continuous flow or bubble CPAP. I think the air leak is the problem of air leak is two things. If you use high level CPAP, like high centimeter water, or the baby is fighting the CPAP. I think these two factors causing the air leak, not. So please avoid to go more than 8 in the first 24 hours in babies whose term or late preterm. In second 24 hours, I go up to 10. After 48 hours, the guys know me, I go up to CPAP of 14. In other babies in other condition, more than 1 month or more than 2 months, they have seen me before, I can use CPAP of 20.
Okay, there is a question from Dr. Ahmed Al-Busrati. Any role of using of diuretics or corticosteroid as it was an old practice?
Absolutely not. Absolutely wrong. Absolutely not. And the reason, doctor, because we know steroid associated with hyperglycemia, and we know steroid associated with hypertension. We know steroid associated with blood dyscrasia. We know steroid associated with spontaneous intestinal perforation. And these fours, its finding and its management have a sequelae on neurodevelopment. Okay? And we know TTN is a self-resolving. So why are we inflicting long-term problems to a baby who will be self-resolving? So absolutely no, wrong to use steroid in TTN and wrong to use diuretics. Absolutely no need. No need to restrict fluid, it's a temporary problem. It's mild to moderate. You just need a little bit of respiratory support, and you need to exclude infection and other respiratory problem. Absolutely wrong to use diuretics or steroid in temporary diseases such as RDS and TTN. No medications like corticosteroid in temporary problem.
Okay, Dr. Mustafa Sabra asks, do we have a specific scale to detect the severity of TTN as
Yes,
using mild, moderate, severe?
yes, yes, definitely.
Specific
Mild,
scale?
yes, mild, less than 12 hours. Uh, moderate, uh, within 24 hours, and moderate to severe within 72 hours. If it's more than 72 hours, 99.99 is not TTN. It's not malignant TTN. It's not. Sometimes there is a little bit of residuals where you need a little bit of oxygen, a little bit of 2 liters of flow for 7 days, and you have no other causes. You exclude pulmonary hypertension, you exclude infection, you exclude cardiac, you exclude everything. So you don't have other finding, and it's still mild. And this is very rare, very unlikely. You don't see it like once or twice a year. And this can persist up to 7 days. So please avoid the term malignant TTN.
Okay. There is a question from Dr. Jonathan. I think you have answered it, Doctor. Will one be correct then to say TTN is a retrospective diagnosis?
I would not say retrospective. I would say a diagnosis of exclusion. And we know in neonatology, we are a preventive doctors. So we hit before the disease starts. So that's why we start antibiotics before 10. And that's why I said it's always correct to use antibiotics, but it's always wrong to continue antibiotics if there is no infection based on silly inflammatory factors.
Okay, dear colleagues all and Dr. Ahmad, everybody, I have allowed the participants to unmute themselves. You can unmute yourself if you want to speak.
So please, if you want to ask a question, unmute yourself, ask a question, mute yourself, and then we'll answer. When you want to ask, introduce yourself so other audience will hear you. Okay? So we have like 7 minutes to start, right, Arula?
6 minutes to start the new session.
Okay, great. So if you guys,
Cup of tea.
Ilhama, you cannot unmute yourself, are you sure?
Yeah, Doctor, most of them are writing the same comment. From my side, I have not muted any of them. I think it is the host.
I muted everybody.
So you are the one, you're supposed to unmute them. From my side, I'm not the one who's muting them. You unmute them.
Yeah, now they can unmute. Let's see Ilhama, why she cannot.
Even Dr. Dana. Dr. Hashim, you're...
I can now.
Yes, now. No. Yes,
it's not from my side. Yeah, please, go ahead.
Yes, Dr. Yahya, can I ask a question now?
Yes, please go ahead. And you are?
I'm Dr. Ilhama, pediatrician.
Yes, go ahead.
Doctor, if we have a case with the surfactant deficiency, how in the first 24 hours I can differentiate between TTN and surfactant deficiency?
How you can differentiate between surfactant deficiency and you cannot answer me yourself? How you can differentiate? What is the diagnostic feature of RDS? We'll take RDS, but how you absolutely sure it's an RDS? There is only one way to be absolutely sure it's an RDS. There is no any other way. Do you know what is it? Anybody can tell Ilhama what is the only one principle that you can say it's absolutely, or not absolutely, but most likely it's an RDS?
Anybody can write the answer.
Anybody want to answer?
Lina Qassab says it is in response to surfactant. If you give surfactant and the baby respond to it.
Yes, Lina worked with me and I think I told her the answer. Yes.
Dr. Jonathan says
prematurity. That's the only way to know it's an RDS. You give surfactant, the child improve. If it's
Dr. Dana says by ultrasound.
By ultrasound, you can differentiate. Yeah, you can find. By X-ray, you can give an indication.
And there's answers at X-ray, Dr. Omar.
It does not tell you it's an RDS. It cannot differentiate RDS. It cannot be absolutely RDS. It can be others.
One more answer.
And the reason why we start antibiotics with RDS is because infection can be like RDS. So it can be like TTN in late preterm and term, and can be like RDS in preterm baby. So X-ray cannot. The only way it tells you, ultrasound tells you this is TTN because it's pathognomonic. In RDS also, ultrasound cannot differentiate RDS from TTN. It can tell you many findings, but it cannot differentiate. I unmuted everybody.
Yes, doctor. Actually, you are the one who muted them, not me, not the co-host. So please unmute.
There was child crying, so I have to, and I don't know who, they are 50. So I need to continue. I cannot search who's like. Kamal,
Can you
now.
please, colleagues, unmute yourself to give the question, then mute back again, please.
Kamal, please mute yourself. Okay, any more questions?
We have 3 minutes to breathe before we go to the next session.
Okay, let me drink some tea and come back in 3 minutes.
In a minute, we should start RDS. We shall start RDS.
Okay, I'm ready. So I will unmute everybody, and everybody should mute him or herself, okay? So you can easily ask questions, okay? Because I can, if interruptions start, there are 63 people listening, and I don't know during the talk who's unmuting himself or herself, and it can interrupt the lecture. So please mute yourself. And if you have a question during the talk, send it privately to Dr. Arula.
We can start RDS.
Okay. So, very important topic, respiratory diseases or respiratory problem in neonatology is RDS. So objective, we'll talk about introduction, diagnosis, prevention, and management of RDS. So respiratory distress syndrome, or previously known as hyaline membrane disease. So let me ask the fellows why they were calling it hyaline membrane disease, HMD. Mona, Yaman, Dr. Mona, Dr. Yaman, Dr. Anud. Dr. Yaman, Mona.
Our fellows.
Mona, Yaman. Why it's HMD?
Yemen is saying that he can't because it's muted. Can we unmute him if he has an answer?
I muted everybody.
Dr. Yemen, try to unmute yourself. Anud is muted as well. I think they are all still muted, doctor. Not from my side.
Wallahi, I unmuted everybody. Let me see.
Strange.
I unmuted everybody.
Muna Tolba says that we cannot unmute, doctor.
Yeah, now we can.
Try now. You see, when I allow children to start, the session become children session. Okay, so Mona, why it's HMD? Mona. You still cannot? Yaman. Unmute yourself. Yaman, Mona.
Yeah, hello, Dr. Yahya.
Yes, go ahead. Answer the question.
Was earlier was called HMD, highly membrane disease, but nowadays the name is RDS.
But why it's HMD? Why they called it HMD? That's the question.
It's because of the appearance in histopathology of the collapsed layers of alveoli.
Yes, Mona, absolutely correct. It is in postmortem, they found a membrane.
Yeah.
Okay, and they thought that membrane and this is a membrane because of decreased service tension, and they thought the membrane is the cause of the disease, so they call it HMD. Okay, well, you can mute yourself. Huh? We don't need to hear music. You see, when I unmute everybody, what will happen? Okay, so they describe it as a typical Britain disease that insufficient pulmonary surfactant in the alveoli. And the pulmonary surfactant is a very complex mixture of phospholipid, neutral lipid, surfactant specific protein. There are 4 proteins. It's synthesized, packed, and secreted by the lamellar body in the alveolar side type 2 of the lung. And the alveolar space and the small, can you please mute yourself? Everybody, mute yourself. Please mute yourself, everybody. So I have to mute everybody, you see? Otherwise I cannot continue. I'm going to unmute. I'm not allowing anybody to unmute him. Mute all. Good. So in the alveolar space and the small airway bronchioles, as we discussed in the TTN, there is a poor supporting structure. So the sole opening depending on the surfactant. The surfactant sit in that alveolar space and it prevents the collapse of the these small areoles, small airways. Why? But because in the other airways, there's still some supporting tissue. As we talked in TTN, this service tension created by the bond of the water molecule. So presence of surfactant as a fat between these molecules prevent this love or this bond or this feeling. And because of that, it promotes or prevent alveolar collapse. And if it's not available, there will be alveolar collapse, which result in small lung volume. So absent or insufficient surfactant resulted in very high service tension and atelectasis. It's either due to developmental immaturity of pneumocyte type 2 or spontaneous or inherited mutation of surfactant-related gene, or inactivation of surfactant, either by inflammation or chemical modification or lung injury. So obviously, preterm babies are prone to RDS because we know that alveolar or pneumocyte type 2 will not develop until the third trimester. And even in third trimester, their number will be increasing successively. So advance in preventive and treatment of RDS improve a lot in morbidity and mortality. But the RDS remain very common and problem because we are going down with the gestational age. Our fight against RDS are three pillars: antenatal steroid, exogenous surfactant, and provision of respiratory support. Rola, mute yourself, please. How we diagnose? We look for risk factors. We do antenatal testing, we do clinical, then radiological, and we have to exclude other diseases. Risk factors. The first risk factors, as we said, lung immaturity. Because structural lung development is a very high or significant risk factor for RDS. Because we know at age of 24 hours, the lung development reached to a point where the lung can provide gas exchange through lung epithelial cell and endothelial cell, or pneumocyte type 1. And it tried to start to provide some service area enough to do oxygen consumption or to provide oxygen consumption for the newborn. Other risk factors, so the first risk factor is lung development. The other risk factor is being male. Other is some ethnicities. Maternal diabetes is another risk factor of RDS. If you have an RDS in a term baby, it's either due to dysfunctional surfactant or there's severe limitation of production or inactivation of surfactant, such as in meconium aspiration. Other type of surfactant deficiency in term babies are a mutation of genes responsible for protein. And this is not a self-limiting transient respiratory distress. It's a congenital surfactant deficiency. And usually the child die without lung transplantation. A mutation such as ABCA3 and mutation of surfactant protein C are associated with the progressive interstitial lung disease and usually late diagnosis. These are lists of type of protein deficiency that present with congenital surfactant disease. There are 4 types and their presentation vary on the protein and the prognosis also varies. So not the purpose of this study, but you know that these are existing. How you know? You give surfactant, child resolve within 24 hours. Once the surfactant, maybe less than 24 hours, once the surfactant is used and there is no new production of surfactant, then the child deteriorate and so on. You give another surfactant, improve and deteriorate. So these are most significant finding. Also remember that the surfactant have some anti-infection property and the child may be prone to infection. Other risk factors is labor, because we know that labor releases glucosteroid. And once the steroid is produced, it contributes to lung maturation. We know that presence of inflammation downregulate the production of many surfactant components. So what is the benefit of antenatal steroid? As we said, the risk factor, the most important risk factors for RDS is gestational age. And it's a very strong predictor of RDS. And therefore, once we need to decide or thinking of giving steroid, we need to confirm lung maturity in the amniotic fluid. Now, because we know that when the lung or the child is premature, mostly the lung will be immature, clinically, we do not need to test for lung maturity. Once the child is preterm, we know it's prone to RDS, and we know the lung is immature, then we need to decide about antenatal steroid. However, we need to exclude some congenital problems, such as congenital diaphragmatic hernia, congenital heart disease, especially if the child is late preterm and term. In spite, we know that taking amniotic fluid for amniocentesis is probably safe in the 3rd trimester to check for steroid, but the wide use of antenatal corticosteroid to reduce the risk of RDS make this procedure unnecessary. Okay. If for any reason you want to test, these tests are very available. We measure the lecithin, which is disaturated phosphatidylcholine, which is a component of surfactant, and it's the most abundant surfactant phospholipid, and its production is developmentally regulated. So the more developed the lung, the more of this lecithin. So measurement of lecithin is a good indicator of lung maturity. However, we know it sometimes contaminated with the blood, and it make it up. Sphingomyelin, however, it's a phospholipid synthesized from the brain, and it's a fix. So we have a test from Abbott laboratory called TDX-FLM2. It's correctly identifying these two factors. But again, remember, when do this test, its contamination with the blood significantly affect the result. So a ratio of lecithin to sphingomyelin more than 2, with some exception of contamination and diabetes and erythropoiesis and erythroblastosis fetalis and asphyxia, it's a good indicator of lung maturity. Can you please mute yourself? Can you please mute yourself, everybody? And therefore, these tests are established for specific cutoff of gestational age. And it's a very good predictor of RDS. There is other easier test, much easier, called lamellar body in amniotic fluid samples. It's rapid and it's inexpensive. And it's, if you are, can you please mute yourself? I don't know why it's hard to mute yourself. Huwaida, please. I'm stopping her. Can you mute yourself, Huwaida? Who's else? I don't know why you're making me stop to unmute. Okay, so this test is very rapid, very simple and non-expensive, and it's very good for resources poor setting. We know the lamellar body is an organelle that present in pneumocyte type 2, and it's responsible for receiving, concentrating, means storing, and then releasing the surfactant. So it's a cornerstone of regulation of surfactant secretions. Once exocytosis of the membrane done, the surfactant is extruded into the alveolar space. Okay? And unwounded phospholipid can be discriminated by light microscopy. So if that surfactant is already distracted, then probably is not related to the secretion. But those surfactant who is not yet distracted, unwounded, or lamellar body can be detected by microscopy, or a fluorescent activated cell sorting, FACS. And more than 50,000 lamellar body per microliter of amniotic fluid has been correlated with mature lung. So this is very quick test. The optical density of amniotic fluid sample can be used as a proxy for presence of laminar fluid in the amniotic fluid. So again, we can use lecithin sphingomyelin, we can use lamellar body or FACS test. Either way, we don't need them because we know with lower gestational age, the risk of surfactant is high. So we can give the steroid without these tests. Okay. So what is the clinical presentation of surfactant, of RDS? So RDS should be suspected in any baby less than 34 weeks. The TTN is unlikely in this. It can be a combination, but it's usually it presents with tachypnea, retraction, flaring of nasal alli, and grunting and cyanosis if you are not using oxygenation pulse oximetry. If you do blood gas, you will see hypoxemia and hypercarbia. If the child is spontaneously breathing, they will overcome the surfactant deficiency by doing a physiological maneuver to increase the functional residual capacity, or what we call it grunting, to optimize gas exchange. These signs are characteristics of RDS, however, they can be of other diseases. So we have tachypnea to increase the functional residual capacity. We have retraction to increase or to increase the negative pressure inside the chest to help lung inflation by using accessory muscle. And that negative pressure is vital for better inflation of lung. Flaring of Early nasi to maximize the air entry into the lung. Grunting, we've talked about it. It's active exhalation, not passive. So the child starts exhalation rapidly so he's breathe in and breathe out, and then breathe in and breathe out rapidly to prevent collapse of the alveoli. Chest X-ray, RDS, remember, is a homogeneous disease because it's a developmental deficiency of surfactant. So it involves all the parenchyma. So there is low lung volume, there is homogeneous microatelectasis, and therefore it contrasted with the airways that has air. So it looks like a ground glass appearance with some air bronchogram. You can use lung ultrasound. You'll see increased B lines until they are homogenized. You'll see decreased A lines because there is decrease in air. you start to see subpulmonary consolidation, you'll see pulmonary edema, you'll see pleural effusion, air bronchogram, and then whiteout. There is no double lung point, and that differentiates RDS from TTN. What is the differential diagnosis? Transient tachypnea of a newborn. Now, we will not talk about it, but the X-ray finding, we check it sunburst pattern. It's a perihilar. It is non-homogeneous. Ultrasound, A line, B line, but the most important is double lung point. Pneumonia, especially due to group B streptococci, it's in babies less than 34 weeks, it present like RDS, more than 34 weeks present like TTN. So because of that, and especially in presence of risk factors such as labor, spontaneous labor, then antibiotics need to be started. If the blood culture is negative, within 48 hours, stop antibiotics, please, without CRP. Genetic disorder of surfactant, we've talked about it, and usually it's present in term and near-term infant. It exactly look like RDS, and it resolve when we get surfactant in a short pace and then deteriorate. There are different type of protein deficiency, and because the protein are important in protecting lung, especially immunoglobulin A, because these proteins are important, the baby is prone to infection. Disordered lung development. These are a group of disorders that cause lung hypoplasia, abnormal lung structure. And if the child is a preterm and has this problem, they're very unlucky because it's usually, but usually this disease occurs in term and near term. How we prevent RDS? We've talked about it. If you need to give antenatal steroid, then it's either on gestation or you do lung testing. And the evidence of importance of antenatal steroid, ANC, is very huge. We know that antenatal steroid will modify surfactant readiness, and it's also modified the lung structure. The target population of antenatal steroid is pregnant women with a baby between 24 to 34 completed weeks, with presence or absence of preterm labor. There is evidence that it might benefit 23 weeks, but most of 23 weeks, they don't have lamellar body and they are not synthesizing surfactant. Because remember, steroid modifies surfactant, upregulates surfactant, but it does not synthesize surfactant. So if there is no surfactant, there is no lamellar body, then steroid will not work. So therefore, 23-weeker is questionable for steroid. A complete course of antenatal steroid is either betamethasone at 12 milligram intramuscular, Q12 hours, 2 doses, or dexamethasone. The preferred, both of them effect is the same, but the preferred is dexamethasone, betamethasone, because it has no preservative and it's only 2 doses. But there is no evidence that each one is better than the other one. There's currently no contraindication of ANC. The benefit of prior treatment for lung maturity, if the labor continue more than 1 week, is questioned. And therefore, sometimes people use second course. Now, the second course is either boosting or rescuing. We will not talk about it, but we will talk about it when we take the antenatal steroid. So either you boost it by 1 dose every week, or you repeat the course. So you keep boosting it by 1 dose every week until labor, or wait and then give another dose. In addition to the antenatal steroid, the principal management of RDS is to improve functional residual capacity. We know that the surfactant is present in distal airways, which is the mainly alveoli and some of the distal bronchioles. And we know these have no backbone, have no supporting structure, and therefore depending on the surface tension to stay open. And that's why we know that supporting these parts by surfactant and improving lung functional residual capacity is the main goal of treatment. The surface tension is improved and protected by presence of surfactant. We know that absence of surfactants cause atelectasis. And we know surfactant, even if it's atelectatic, it will cause re-expansion. Why? How that? You know the surfactant is a bipolar. So the polar head is of the surfactant interact with water molecule and break the bonding, the love between the hydrogen. And therefore, it prevent the tension and prevent the stickiness of the alveoli. Inadequate or dysfunction of surfactant increase that bond and increase the tension and causes the atelectasis. How we do improve functional residual capacity? We provide CPAP. Now, CPAP for RDS is a little bit more different, a little bit, than a CPAP of TTN. Because TTN, the risk of air leak is higher than RDS with CPAP. We can use CPAP of different type. We have 3 types. We have fixed flow or continuous flow CPAP. We have intermittent flow CPAP, and we have bubble CPAP. And we use different interfaces such as nasal prong, nasal mask, or face mask. To give CPAP, the child should be spontaneously breathing. To improve spontaneously breathing, we need, of course, caffeine. So these are important to start CPAP, and remember, baby should be breathing. And the meta-analysis of using CPAP showing a very important tool of treatment of RDS. And we know that CPAP treat RDS without increasing the incidence of bronchopulmonary dysplasia. As we said, the devices are either bubble CPAP, variable flow device, or mechanical ventilator continuous flow CPAP. Some bubble CPAP may provide some oscillation, and that probably, if you need an oscillation, probably you are helping in recruiting more alveoli and clearing CO2. And how that, we need to have another session about non-invasive ventilation to know why. However, whichever device you use, okay, you have 2 options. Either start from low and go up, or start from up or go down. I like to start up and go down, while in TTN, I use low and go up. And the reason, as I told you, the risk of air leak is way higher. And also I use something called dynamic CPAP. So I don't use fixed tone. I change the CPAP always depending on the performance. And the reason for that, because I want a child to rebreathe, to wash CO2. And if you are not allowing the child to rebreathe because he's resisting CPAP, or you are giving CPAP during exhalation, then probably you will cause CO2 accumulation. Now, other development that allowed us to use CPAP is development of a humidification device. And we start to give CPAP through nasal cannula, such as RAM cannula. And also we start to give heated, humidified, high flow cannula without even CPAP. And the difference between CPAP Okay, so well, we can give the chronic lung disease in another session, Rola, because chronic lung disease is important, and I think we have to give it in another time. So I'm not going to give it in this session. It is very prolonged. It needs more fuel because it's all neonatology. Okay, so I'm going to pass these details. Again, there is one trial comparing the CPAP with heated, humidified, high-flow nasal cannula. Find no difference. The performance are almost same. However, I prefer CPAP because I can see pressure and I can see the flow. And I prefer high-flow, humidified cannula if there is local trauma. And the reason because CPAP with variable flow cause the baby more comfortable. However, the pressure of the CPAP on the septum can be problematic sometimes. So to use HF and C or CPAP depend on the situation. However, the studies say no difference between both of them. There are variable interface of CPAP, nasal cannula, nasal mask, nasal prong, facial mask you can use. Okay, but the most important, you sometimes might cycle, is to prevent local damage from use of CPAP. CPAP is a good device, but need lots of care. So you need good nursing. If you don't have good nursing, they'll probably use nasal cannula. How to initiate CPAP? As I said, you can initiate from low, go up, or from up, go down. Check your situation, start your level, assess, and change. Be dynamic. The purpose is to increase CPAP, to increase inflation, and give room air, or at least less than 30% FiO2. If you persistently need more than 30% FiO2, then probably you need to upgrade your management, surfactant or ventilation. How to wean? I go down first FiO2. I love to wean when it's less than 25%, but it's okay to wean when it's less than 30%. I usually continue CPAP when I reach 5. Some people reach to 4 until they discontinue CPAP. You don't need to hurry and disconnect CPAP in a chronic baby if the baby is not growing. So if you have even no respiratory support and your baby, when you off CPAP, not growing, probably he or she is putting too much work on breathing and losing calories and not growing. So if you have any growing premature baby, you probably need CPAP and you have no local problem. Then don't be hurry and take off CPAP. What is complication? Overdistension. And again, this is very relative, depending on the gestation, depending on surfactant administration, depending on pathology. However, when you cause overdistension, it's exactly the same of underinflation, because overdistension causes inadequate tidal volume and lead to hypercarbia. It can tamponade the alveolar capillary bed and cause perfusion ventilation mismatch. Also, it can press on the cardiac venous return and cause poor cardiac output. Other complication of CPAP is air leak. And we've talked about it lots. Other complications, underdistension and atelectasis and poor oxygenation. Because remember, you need to distend the alveoli to be equal to the pulmonary bed. So you have 100% contact between the alveolar bed and the pulmonary bed to maximize the oxygenation. If the alveolar bed less than the pulmonary bed, you will have poor oxygenation. And therefore, underinflation is not good. The other problem is nasal septum trauma, persistent problem because of the pressure. Need lots of change, need cycling, change, need monitoring, need good nursing. So we gave antenatal steroid. We are on CPAP. CPAP should be started at 2 minutes according to golden hour, at by best situation. And people now starting it once the head pop up out of the vagina, before even cutting the cord. And now people putting the interface with the delivery set and with the C-section set. Now you need to give surfactant. And this is one of the milestones of the change the neonatology. So let me ask the fellows, who discovered the surfactant? Anybody know? And when first time was used? And where? Fellows? Unmute. Also, you cannot unmute yourself. Fellows? Toramuna? Toryamin?
Doctor,
Yes, when first time, which year?
in 50s?
In 50s, are you sure, or you're guessing?
Just I came across.
Oh, okay, no, it's not in 50s, because you know Kennedy?
No.
You know the USA president, Kennedy?
Yeah, I know.
Yeah, his child died because of prematurity, right? You remember?
No, I don't have this information.
So the surfactant was not available, and his child died.
Dr. Ahmed Dane says the Japanese doctor.
What is the name, Ahmed?
Dr. Dane.
I'm not sure. Unfortunately, I'm not sure. I have read about it. I think it is in 70s, if I'm not mistaken.
Dr. Dane says in 80s.
1980. So let me tell you. So her name is Fujira, and and he was a fellow in United States, and he tested it on animal with his mentor, his supervisor, and it works. So they want to try it on a human being, but FDA did not approve it. So he went back to Tokyo and tested on 6 babies and works very well. And within 1 year, until 1968, there was more than 200 trials of surfactant. So it was a fellow. It was a fellow and was Japanese, you're right, and it was 1980. So wide use of maternal antenatal corticosteroid reduced the incidence of RDS. However, the risk remain high because we're going down in the gestation. And therefore, we have more surfactant deficiency or RDS, respiratory distress syndrome, due to surfactant deficiency. And therefore, one of the cornerstone, in addition to antenatal steroid and CPAP, is providing surfactant. Okay. There are many types or brand of surfactant approved. There are almost 6. The question is how we give it. Should we give it prophylaxis versus therapeutic? The evidence demonstrate that advantage of early treatment is very good. However, you will end up intubating babies and giving surfactant that might actually not needing it. And when we say prophylactic, we say all the babies intubate and give surfactant within 30 minutes. So people say, why we do that? Why we don't give CPAP? We give steroid and wait until the baby turns symptomatic while on CPAP, and we cannot go down to 30% when we're using high centimeter water and it's still symptomatic, then we'll give surfactant. So that's called early rescue. But some people also wait more and give it after 2 hours. So that's called late rescue while on CPAP and receive antenatal steroid and more than 2 hours. So the evidence shows that early rescue is the best. Okay, and again, the prophylaxis is good if you give it within 30 minutes. However, as I said, it means that you will have lots of baby intubated and giving surfactant, and they don't need the surfactant. And we know the damage to the lung can be caused by ventilation. And we know that giving only 6 breaths, mechanical breaths, can cause lung injury. And therefore, that is not indicated unless the baby is symptomatic. Or if you intubate a baby who is preterm for other reasons, for apnea or for, then you need also to use to give surfactant. Or if CPAP is contraindicated, you have abnormal nose, or the baby is not tolerating the CPAP, and you intubate, you need to give surfactant. There are a variety of types of surfactant prepared from animals, from cows, from pigs. And there's also synthetic. It's a combination of phospholipid and protein B and C. So I'm not going because we have a study, a presentation about surfactant. So these are types of surfactant. The Bless of Canada is not mentioned here, but we have Survanta, which is Puractant, and Infoserv, which is Calfactant, and Curoserv, which is again Protectant. So basically you're giving 100 milligram, around 100 milligram. Apart from Curoserv, because it's a small volume and taken from porcine, they give 200. But nobody is giving 200. Okay, all the practice to give 100. But that's the company normogram. How we give? Usually the dose is 100 milligram per kg. Can we repeat? Yes, we can repeat within 8 to 12 hours. How many doses? Maximum 3 doses. There's good evidence for first dose, not a great evidence for second, and very unlikely of benefit as a third dose. How we administer it? The standard is through ETT. Can we give it? We can give it as an open method or as a closed method. Closed method within the closed suctioning system, or open method, you disconnect. No, we don't want to talk about that because I love the closed method because that's less risk of infection, less risk of recruitment, de-recruitment injury, and less risk of lung injury, but I don't have evidence. It's just physiological evidence. I think closed method is the best. Here is written is chest X-ray, but it's actually not necessary to do X-ray. So if you have a premature baby, you are on CPAP more than 30 minutes, you need FiO2 more than 30%, and you are on CPAP 8 to 10, probably you need to give surfactant. If you are intubated and you are less than 28 weeks or less than 30 weeks, you probably need to give surfactant. You don't need to do. However, sometimes X-ray indicated if you don't have ultrasound to know the level of ETT. Okay, most people administer it through feeding tube, but again, closed method is way better. Yeah, almost done. You can give it in one aliquot or many aliquots. You can give it in non-invasive way, minimal invasive surfactant or LISA. What's complication? Air obstruction. If you give it too fast, you obstruct the upper airway and you cause probably a little bit of high CO2. So don't do gas right away after surfactant. Wait a little bit. You can use air leak because you expand the lung due to increased compliance, and you might cause some air leak. So you need to be hemorrhagic pulmonary edema you can cause because all of a sudden you improve compliance and you increase perfusion and you relax the pulmonary vasculature, flow of blood, and sometimes cause pulmonary, especially if PDA, associated with PDA. How we improve CO2 elimination RDS? Caffeine therapy with CPAP. And so that's why people ask me, should I continue caffeine while I am ventilated? The answer is yes, this is one of the reasons. How we improve CO2? Proper mechanical ventilation. Volume targeted, pressure limited. Remember to use dynamic CPAP. Don't be pipophobic or pipophilic, or CPAPophobic or CPAPophilic. I'm going to pause this. Now, when you do monitoring of ventilation, target a tidal volume of 4 to 6, use volume limited, time cycle. You can use baby-derived ventilation, such as PSV, but remember the baby should be breathing and not exhausted. Please use graphics and loops to monitor the baby, not gases. Gases cannot be as frequently as needed to control ventilation. So if you need proper ventilation, look at your typical loops and graphics, not in addition to the oxygenation and child condition clinically, not only blood gases. Outcome, we are in the pre-surfactant era. The RDS usually resolve within 2 to 4 days if the child survives. And that usually preceded by a stage of what we call it spontaneous diuresis. Wide use of antenatal steroid and CPAP and surfactant make the course of RDS unpredictable. Okay. So babies more than 30 weeks without any complication usually resolve with no long-term sequelae, but below 30 weeks, there might be some long-term sequelae. So take-home messages. Respiratory disease is a disease affecting preterm baby caused by insufficient pulmonary surfactant. Antenatal steroid given to the pregnant lady anticipating preterm delivery can prevent RDS. Treatment is establishing and maintaining functional residual capacity by giving continuous positive airway pressure and administrating surfactants. There are very good articles about surfactants, especially the new review on surfactant of respiratory distress from American Academy of Pediatrics in 2014. It's a beautiful article about RDS. And I don't think I will give chronic lung disease today because time is short, and I think, guys, you are tired, but I'm ready to take questions.
Okay, can we start
Yes,
with
Dr.
one
Yahya?
question?
Yeah, go ahead.
Yeah, Dr. Yahya, what is your best practice or experience in early rescue by giving Cervanta in the theater or labor room for extreme preterm babies?
Okay, so the answer is no, you don't need to give for many reasons. First, surfactant is not an emergency drug. That's one. Second, you need a stable, quiet circumstances. Third, there are other complications can happen is way worse than RDS. These are hypoglycemia and temperature instability. And as we know, the baby might not be symptomatic unless within a short period of time. And we know some of the RDS might respond only to CPAP. Therefore, the standard practice is to give CPAP within 2 minutes, control the room temperature, put the baby inside a suitable place to control temperature, whether you use a plastic wrap and enclosed incubator and so on. Try to put a line so the sugar can hit the baby within 10 minutes. And remember, some of the babies are intubated because of apnea, not RDS. So caffeine is way more important than surfactant. Antibiotics and surfactant, there is no need to give them in the labor room. CPAP Starting IV fluid and started caffeine is way than important. And controlling temperature. Once you bring the baby to the labor room, you can give it. And you have a time, early rescue, between 30 minutes to 2 hours. And your patient should be on CPAP more than 8 to 10, and FiO2 more than 30 for at least 15 minutes. And remember, surfactant need to be thawed down to room temperature. And that takes usually 20 minutes. And if you want to fasten it, then you'll have denaturation of the protein. So for all these factors, you should not give surfactant in the labor room. There are other logistic factors. Most of the nurses and the environment and the obstetrician, their tension, especially if the mother got complication, no experienced staff. So that is not suitable logistic environment to give surfactant. So I am not with giving surfactant in labor room. Did I answer your question?
Yes, Dr. Dan. And you are another question is so you advise to give prophylactic Cervanta for those extreme preterm, regardless what is the condition?
No, I didn't say. There is absolutely no indication of prophylactic.
Prophylactic.
No prophylactic, not indicated.
Even for extreme preterm?
Even for preterm, if the preterm baby and on CPAP and the CPAP is somewhere a bit less than 10 and the FiO2 less than 80, you don't need to give surfactant. So remember, RESCO is baby more than 30 minutes, less than 2 hours, and symptomatic. And remember, we said symptomatic on CPAP, more than 8 to 10, FiO2 more than 30% for at least 15 minutes, then asymptomatic and baby is retracting clinically, or sometime the PCO2 is high and you cannot maintain the oxygenation, then that's an indication to give surfactant. Now, if you are intubating for another reason, such as apnea, then yes, you need to give the surfactant in very small babies without symptom of RDS.
Okay.
Okay.
With
Dr.
the
Yahya,
8%?
Yeah, Jan, go ahead.
No, I'm telling you are recommending until 80% FiO2, we will not give a surfactant if the baby is actually premature.
80%? What mean 80%? FiO2, 8%?
FiO2, yes.
30, not 80.
Okay.
30.
Dr. Hafiz, it is 30, not 80. Dr. Yahya, there is a question from Dr. Julien. There is a question from Dr. Julien.
Okay.
Is a non-distressed but periodic breathing can be a concern? Can patient be discharged with this condition to home?
Periodic breathing, I don't understand the question, but why you want to discharge a periodic breathing? Because periodicity happen in prematurity. So how you diagnose a periodicity in, I don't know, I don't understand the question, but we discharge babies if they are more than 35 weeks, they are on non-respiratory support, they are not on IV fluid, they can eat adequate amount of milk to grow, and they can control body temperature. And usually that happens when they are 35 and usually more than 1.8 kilogram. So, and they should be breathing by their own. Most of periodicity happened before that. If you have periodicity after that, I think either you are wrong in the diagnosis, you might have like seizure, or because periodicity never happened unless you expose the baby to hypoxia. So periodicity can happen in adult when you go on high altitude. So I really don't understand the question to answer.
Dr. Julien, if you can come again and ask, that would be appreciated. Doctor, a question from Dr. Rabia. What is the minimal interval between the 2 doses of surfactant?
8 hours.
Okay, Dr. Rabia, fine. Dr. Omar Ahmed.
And I want to ask the fellow, why 8 hours? Any idea? Mona? Is Mona left? Or she's here?
I can see her name.
Mona? Mona? Doctora Mona? Well, she's logged in, but maybe she left.
Yeah.
Anyhow.
Okay, another question. Can RDS present with respiratory failure type 1, or there is always a hypercapnia?
Well, first, I don't like the term respiratory failure. I don't use it, and there is no evidence of what is respiratory failure. It's all subjective terms, because when we say an organ failed, mean this organ needs support. Okay, so I don't believe in term respiratory failure. That's one, and second is ventilation usually used for either hypoxia or hypercarbia. Now, the respiratory failure also not a favorable term because now we have no normal CO2 level. We have permissible CO2, and that permissible CO2 varies with the condition and with the gestation and with postnatal age. So in certain gestation and postnatal age, 45 might be not good. In other one, 70 might be acceptable. And therefore, the term respiratory failure is not acceptable. But yes, if there is hypercarbia above the permissible, or if there is hypoxia, so FiO2 less than 90 for a considerable period of time, persistent, both, saturation despite using maximized non-invasive and oxygen supply, more than 40% for a considerable period of time, then that's another indication of ventilation, yes.
Okay. A new question, Dr. Hashim. Is there any superiority of nasal CPAP comparing to NIMV in the treatment of RDS, non-invasive mechanical ventilation?
No, CPAP is better. There's no difference, no superiority, but in my practice, CPAP is better because in RDS, as we said, the distal airways and the alveoli have no supporting tissue and it's losing the surfactant. So if you have no CO2 high, if you have no hypercarbia, there is no point of using non-invasive ventilation because basically in non-invasive ventilation, you're providing tidal volume to wash CO2. So if you have normal CO2, absolutely you need CPAP because you need a good distension pressure. And in non-invasive, you might not give a good distension pressure. If you have high CO2, then yes, the non-invasive might be indicated.
Okay.
But there is no evidence the superiority of either.
Okay, thank you. A question by Dr. Hadi Faqih. What's your target of SpO2 when the babies are on mechanical ventilation?
Oh, so that's a very hard question because if you know the supported trial, they found that they have two groups, 88 to 91 and 91 to 94, and they found the high death rate in lower group and less in the upper group. However, they found in the lower group less ROP. And therefore, the support trial was terminated, and there was a big court because one of the baby passed away because of trial, and trial has to be terminated. So the current practice, in my opinion, is depending on the gestation. And if you reach to the chronic lung disease, you will see target. So I think in premature babies, probably less than 32 weeks, I would go with a target between 91 to 94. And if the baby more than 34 weeks, I would go with a target 94 and above. Where to put the alarm? I usually put it 95 or 97 down to 85. So the target is between these numbers, but the alarm, you can set it 5% above and below.
Thank you, Dr. Yahya. Fi question, Dr. Ali Qais. He's saying, we used to give aminophylline. Now we are giving surfactant and CPAP. Newly, we started to give caffeine. Dr. Yahya, mean the caffeine before the surfactant and the CPAP? I guess he's talking about the golden hour.
Well, first, nobody is using aminophylline. That's totally incorrect, neither before nor after. If you're giving, and this is a totally against standard of practice, and it's wrong practice. We never give, we never did, and we will never do. And there's absolutely no indication of aminophylline in neonatal practice for many reasons. First is less therapeutic index between aminophylline and between the therapeutic dose and toxic dose. And aminophylline has no, caffeine is way better diesterase inhibitor. Although aminophylline is better dilator, bronchodilator, and better diuretics. Okay, so I don't know from where you have this. If you have an evidence that aminophylline was used, please provide. So first, using of aminophylline is nobody, please, everybody's hearing me. Absolutely, 100%, not only 0.111% aminophylline was used or should be used. Second, caffeine should be used and should be hitting the baby within 20 minutes. And the reason for that, because sometimes we intubate because of apnea. And once you intubate and you give 5 or 6 breaths, you already do some injury. And because we have CPAP and we can humidify now, then we can start CPAP to prevent apnea and to prevent RDS. We give caffeine to prevent apnea, and therefore both of these are indicated before surfactant. In addition, we know hypothermia, so we need to control the temperature, and hypoglycemia, we need to control it before the surfactant. So these are very important to be successful not intubating a baby. Whatever the gestation, I have treated babies 24 weeks without intubation. So caffeine is indicated, yes. Aminophylline never, and should not be given to newborn babies.
This needs another lecture about, another session about golden hour, doctor.
There is a golden hour and there is chronic lung disease. We'll talk about all these.
Yeah. في Dr. Sondos Khudair asking if the premature need advanced resuscitation and need intubation in the delivery room, is it absolute indication for surfactant administration after we stabilize?
Well, first, once you stabilize, you should move the baby. And again, surfactant is not an emergency drug. If you think that the baby will not be moved within 2 hours, then you can give surfactant, especially if your resuscitation room is a designated room with controlled temperature and you can absolutely provide monitoring and proper ventilation, you might need give it. But if you don't have that staff and setting, then it's better, way better, after stabilizing the baby, because most of the baby, you stabilize them, they need ventilatory support, and they need some inotropes. If you can provide both of these, you stabilize baby, move to an ICU. Okay, and I prefer an ICU to be given in a very well-controlled circumstances. If that facility or that logistics are available in the resus room, then yes. If it's not, then you need to transfer the baby to an ICU.
Okay, thank you. Dr. Rubia asking, some people give surfactant as early as 4 to 6 hours after the first dose. Please elaborate why not to give earlier than 8 hours.
Because the recycling in the lamellar body, the release from lamellar body takes, and the digestion by phagocyte, it takes about 8 hours. So giving the surfactant, remember that the lung drown, you know what is drowning? When you submerge your head in the water and you start to breathe water, you need 20 ml per kg to be drowned. So giving more surfactant causes mechanical obstruction and maybe causing kind of drowning without benefit. Now, if your child is not improving about after giving surfactant, then think of other causes, such as infection, such as air leak, such as cardiac compromise, such as improper ventilation, such as hypothermia or hypoglycemia or CNS problem. There are other factors, but repeating the surfactant again and again will be, you only, when I see people give surfactant less than 6 hours, they are desperate. They are desperate physicians, and probably because of the setting. So why? Because the recycling of the surfactant, digesting the surfactant, absorbing it, and then synthesizing it, and then store it in the lamellar body takes about 6 to 8 hours. So from giving it to denaturalizing it, it's not less than 8 hours.
Okay,
And
I
you
hope
can
this
read it.
answers. Okay, I hope this answers your question, Dr. Rubina. Dr. Ahmed Dana asking, do I need to give surfactant if the baby is intubated due to apnea, although his oxygen requirement did not cross 30%?
Yes, you need to give. And the reason was that, Ahmed, if the baby deteriorated later on and the baby was intubated, it's hard for you to defend yourself. So from medical legal point of view, if a baby less than 30 weeks and intubated, I would give.
Even if his oxygen requirement did not cross 30%?
Yes, because later on might deteriorate due to RDS.
Okay, tamam. Thank you.
I
Dr.
personally
Julien,
would give. But not giving is not correct if nothing happened. But if something happened later on after 1 month and the baby deteriorate and become very sick, and they told you, why you surfactant? You cannot defend yourself.
okay,
But nothing wrong with not giving. Yeah, go ahead.
Tamam. Sorry, Dr. Julien is asking, when is the best time to discontinue caffeine citrate?
That is very
I know you like this question.
that is very hard question. I think we've talked about it, right?
Yeah, we touch it.
Oh no, we talked about apnea yesterday in the last session.
Yes. Dr. Julien, I think she was not, or he was not there.
Very hard to answer, but I would say if you are on non-respiratory support and you are free of apnea for 7 days, 5 to 7 days, I would stop the caffeine. Now, most of the babies you can stop by age of 34 weeks, but the younger the gestation, the longer you will stay. So you might need to continue caffeine up to 42 weeks. But to stop caffeine, usually should be apnea-free, no respiratory support, and most of the babies should be growing for at least 5 to 7 days.
Do you discharge babies on caffeine, Dr. Yahya?
Sorry?
Do you discharge babies on caffeine?
Yes, I do.
Okay. A new question
if the
from
baby is calm, baby full feed, growing, but you have recurrent apnea. Yeah, I do. And then I bring them back after 1 month and do sleep study. And if it's a central, I would continue. And if it's obstructive, I would recommend home CPAP. And I would continue sometime up to 3 months. Unlikely you need CPAP caffeine more than 3 months. We use CPAP always. We drink tea and coffee, me and you always, we use caffeine. So no problem of using caffeine. Very high therapeutic index. Toxicity not less than 80 milligram per kg per day. Yeah, go ahead.
Okay, Dr. Muhammad Hudayfa asking, what is the risk?
Concentrate on RDS and TTN, don't deviate.
Yeah, I think this is what's going on. Dr. Muhammad Hudayfa is asking, what is the risk of caffeine in your practice to increase IVH or NEC? What is the risk of caffeine in your practice to increase the rate of IVH or necrotizing enterocolitis?
Zero. Yeah, some people say there might be the increase, disturbance of splanchnic blood supply, but with the caffeine, with the IVH, I have no evidence. I don't know. I have to go and read. I never heard. I have no idea. I don't know if there is a risk. Anybody know if there is a risk? I don't know. I don't know the answer. Probably I need to go and read, but I never came across that caffeine cause IVH. Anybody?
Okay,
Anybody know that caffeine cause IVH? Rula?
Not up to my knowledge. Not up to my knowledge.
I have to read, but
yeah. Okay.
Thank you.
Dr. Mustafa and Dr. Ahmed Dana are asking almost the same question regarding the criteria for giving more than 1 dose of surfactant. Criteria for giving more than 1 dose of surfactant, and how many doses you can give in case of severe RDS.
I don't know what is the severe RDS is, but I would give surfactant if you need FiO2 persistently more than 40% to keep target saturation. So if you give surfactant and the baby improved, so the baby you were on more than 40% and you can keep and slowly deteriorated over 8 hours, you can repeat. Now, the evidence for the first dose is good. The second dose, not as good. And rarely you read third dose. Now, can you repeat? Yeah, you can repeat. You can give surfactant even an adult. But what is the benefit? It's not for RDS, because remember, RDS is a self-limiting disorder and usually should recover within 4 days.
Okay, 3 doctors are asking how can they get a copy of the presentation?
You can get a copy of the PDF, and then you can the talk is on the YouTube if you want. It's not a it's just a review for fellow. So it's just a text that I am reading. I mean, it's not like a real lecture. It's just a review for fellow, just to encourage them to read. So you can get a copy of it, of the PDF, not it's the presentation itself, because it's a big size. We can provide it to anybody, Rula, we can provide it to anybody, but it's not a lecture. Yeah, go ahead.
Okay. Too many doctors are saying thank you for the presentation. I think Dr. Hafiz has a burning question.
Yeah, go ahead, Hafiz.
Okay, I have 2 questions. One question is for Sarventa, for protein B deficiency, how many doses and what is the indication? First one. Okay, second question, is there any role of Sarventa like before the 4 times normal dose of given the clear evidence of meconium aspiration syndrome? These 2.
Yeah, so how many doses you can give as frequent as you can. But again, the evidence for first dose, Hafiz, is very strong. The evidence of second dose is not as good. And the evidence for third dose are weak. But how many doses? You can keep continuing. For example, if you have congenital surfactant deficiency, you have to keep giving it. I have a baby who was giving and then ended up with lung transplant. I gave him 10 doses. So you can give as big. But for RDS, because RDS is a self-limiting disorder, it should disappear within 4 to 5 days. Giving frequent dose, I don't think it's I think if you need a second dose, you probably need to think of optimizing your management, your temperature, your sugar, your ventilation, your oxygenation, your inotropes, more than really a second dose. But sometimes you need to give it. Now, is there indication of meconium? Absolutely yes, because remember, surfactant, as we said, disperse between the hydrogen bond of the water and decrease the surface tension. So having a protein, one, from meconium, having atelectasis from meconium, having a pneumonitis from chemical irritation of meconium, all interfere with the surface tension. So make it more and cause atelectasis. So giving surfactant is an indication in meconium surfactant. Although FDA approved surfactant only for RDS, but there is a clear evidence that surfactant can work for meconium. And yes, you can give surfactant for meconium.
Meconium, but the volume is that there is a practice 4 times the normal dose. Is it correct?
4 times? No, absolutely not. There is no indication to do that. The dose of surfactant, whatever the condition, is 100 milligram of phospholipid per kg per dose. You don't need to give more than that.
Any more questions?
No, thanks.
Yes, Dr. Yahya, I need to ask a question.
Dr. Yaman.
When to consider high frequency and RDS extreme preterms, and is it really safer than conventional or not? Thank you.
Is it safer? Evidence-wise, there is no evidence. When to use it? When you're optimizing your mechanical ventilation, but you still need more than 40% FiO2. You already gave surfactant. You optimize your blood pressure and inotropes. You optimize your temperature and sugar. You optimize your ventilation, your tidal volume, your loops and graphics looks great. And your FiO2 more than 40% for more than 15 minutes, you need to use high frequency. Some people use it electively. So they start for certain gestational age electively. Now, high frequency are 3 types. So I'm not sure which one you're talking about. High frequency jet ventilation, high frequency oscillatory ventilation, and flow interrupter. Now, if you Google my name and you Google the Cochrane review, I have very nice Cochrane comparing Cochrane review, comparing high frequency jet versus high frequency oscillator in premature babies with pulmonary dysfunction. So the indication after optimizing everything, and you still need FiO2 more than 40% for a considerable period of time, more than 15 minutes, to achieve the target saturation. And if you cannot also reach within the permissible CO2 level. These are two indications for high frequency.
Another question, Dr. Yahya.
Go ahead.
Yes, please.
For babies who are RDS, from the histopathology and physiopathology of the disease, there is a chance of increasing lung fluid or fluid retention. So do you advise to do any fluid restriction for the first couple of 3 days or first 72 hours? And as a complication also, PDA might be there.
Okay, so for PDA, yes, you restrict. For RDS, no, you do not restrict. RDS is a surfactant deficiency, has nothing to do with fluid. PDA, yes, you restrict the fluid.
Thank you.
Dr. Yahya, I am getting messages. Thank you for the lecture. Thank you for the opportunity and all this. I will not nominate name by name. يعني consider all.
Thank you, everyone. Thank you, everybody, for attending.
Would you like to say something about the coming meeting next week?
We will give chronic lung disease because it's a long session.
So it will be 1 hour, we will say, or 2 hours?
Will be probably 2 hours.
Okay, chronic lung disease. Is there any other topic? Any other topic will be given?
All these questions will be included.
Okay, tamam. So prepare your questions for the next session and wait for the link.
Thank you very much.
Thank you very much, Dr. Yahya.
Thank you very much, everybody. Have a good day.
Thanks a lot. Thanks, everybody. Thank you.